In hepatic trauma, now getting into the solid organ part of this, in hepatic trauma, our senior trauma surgeons think that this is probably one of the most beneficial things that we offer the trauma service. Between liver lacerations that we can repair, or not repair, but at least turn into a favorable environment, this and deep pelvic bleeding are our most useful procedures for them. We're lucky in the liver that it has a dual blood supply, so we can be pretty willy-nilly on, well, I wouldn't go that far, but we don't have to be technically precise because the risk of ischemia to the liver is limited because the portal vein helps maintain liver function. Be careful of cystic artery, always identify it and make sure where it is. You can have nice technical success, and then you have gallbladder infarction and the whole thing turns into a mess. So you can grade liver injuries if you want to, depending on the size of the hematoma or the depth of the laceration into the organ. We tend to work in the middle grades, not because we grade them and say, oh, this is a grade 3, this needs to go to angio, but the grade 1s tend not to be actively bleeding, and the grades 4, 5s, and 6 tend to be hemodynamically unstable, so we get the 3s and 4s because that's where they fall clinically. High correlation there. First liver case was a 54-year-old gunshot victim with only solid organ injury and no bowel injury. You can see a large laceration on the right side of the liver with a pseudoaneurysm on the left end of the left edge of the laceration and the hematoma around. This would be grade 3 liver laceration. We did an angiogram showing bleeding up here in the right upper quadrant, and then a selective hepatic angiogram showing bleeding from a branch of the right hepatic artery. And we got out there with a microcatheter, and we showed that this was, there actually is a arterial portal fistula right here, and it's fed by multiple branches. So instead of getting in here and coiling this and coiling that, I think Claudio did this case. I think we put glue in there and stopped the bleeding. You can see a nice glue cast here on the completion angiogram and no more pseudoaneurysm. This is how he was discharged from the hospital on follow-up CT with liver cast here. A nice, no more pseudoaneurysm here, a little residual hematoma here on the side. Second liver case is a 16-year-old motor vehicle accident with a liver laceration. Kids tend to do well in solid organs, particularly in the spleen, but this kid almost ripped her liver in half here. This is a grade 4 liver lac with some active extravasation again on the left side of the liver laceration. Angiogram shows bleeding here from a branch of the left hepatic artery. You got out there with a microcatheter. This was fed by a single branch and it was coiled successfully. No more bleeding. Nice. This is how she came in. This is how she went home. Good result. Splenic injury, we still argue about this one. Splenectomy is a traditional treatment, but conservative therapy is becoming more and more popular. What our role is depends on where you work. Different institutions deal with splenic injury in different manners. How do you do it? Who gets it? There's a recent study from Long Island that says everybody should have a main splenic artery embolization distal to the pancreatic artery, and if they have extraparenchymal bleeding, then that should be microcatheter. If it's just intraparenchymal, just leave it alone. Other studies, one from Maryland, showed that there was really no statistical significant difference between microcatheter and just a splenic artery embolization. So we're still working this one out, how to do it and who should have it done. One study has shown, it was the Maryland study again, showed people with splenic AV fistula tend to have a poorer outcome. The overall outcome in splenic injury is about 80 to 90% successful, but those that had AV fistulas had a 40% failure rate. And in the splenic embolization environment, we have a risk of abscessing the liver, just turning the liver into one big abscess. It's a dirty place. These people have to be on antibiotics. They also have to have a pneumovax to protect themselves against encapsulated organisms. Again, you can grade these things as you want. We tend to work on the middle, not because of their grade again, but because of the way the correlation with their clinical presentation and grade of injury go together. This was a 9-year-old motorbike accident with a splenic injury to the mid and lower poles. And you can see multiple feet. You have to watch out for the pancreatic artery branches when you're doing a splenic artery embolization. You don't want to have a successful embolization and then have massive pancreatitis. You can see multiple, there's my pointer here, multiple branches down to the pancreas over here. But we got out as close as we could, and with a microcatheter again, and this region of interest was fed by multiple vessels, and glue was chosen to use. We got a little bit of glue a little bit higher than we probably wanted to, but we did maintain some splenic function here, and we maintained the pancreatic function as well. Second splenic trauma case was a motor vehicle accident with a large splenic laceration in the pseudoaneurysm near the hilum of the spleen. Again, you can see multiple pancreatic feeding vessels here, as well as a colonic branch, so variant anatomy here. And so we wanted to get as close to this thing in and leave all that other extrasplenic vasculature intact. Went too fast. We've got some microcatheter out here, got some coils out here, no more pseudoaneurysm, and everything else that is extrasplenic was maintained. This is not a trauma case. This was a case of Marcello's not too long ago, a couple months ago, I believe. This is a liver transplant case with a splenic stele. Had decreased liver function because the large spleen was taking all the blood away from the liver transplant. And so the goal here was to embolize the splenic artery to improve flow to the liver. But we found later that this patient had dysfunctional platelets. They had a normal INR, PT, PTT at the time of the study. Marcello got in there and put an Amplatzer plug in the splenic artery, and it looks really good. But then he does this completion angiogram, and it's just flowing by just as fast as it ever was. So then he packed a bunch of coils behind it, and it kept on flowing just right on by it. So Marcello had a smart idea. He's a smart guy. He got some blood out of the patient. He says, I'll just wait for some clot to form, and I'll just throw this clot back into the patient, and we'll be done. And it never clotted. I don't know, how long did you wait? 20 minutes. Still didn't clot. So we said, this patient must have some coagulopathy we don't know about. So then he put glue in there and got a mechanical closure on, and the patient ended up doing quite well with that. It took a lot of work, took a lot of thought. Renal injury, the last part of my talk. Again, we're a little lucky in the kidneys because they're in the retroperitoneum, and it tends to be a tamponading environment. So usually we have a little time to buy in these patients, especially if they're the lower grade injuries. If they're higher grade injuries, they tend to go to the OR. We like to get as super selective in all renal injuries as we can in order to maintain as much renal function as we can. A lot of these are blunt trauma. A lot of these are also biopsies that have done in patients with glomerular nephritis. And again, you can grade these things if you want to, based on the amount of hematoma or the amount of laceration. Here's a patient with a left renal artery injury, a left renal artery pseudoaneurysm in the mid portion of the left kidney posteriorly. The left renal artery angiogram showing the pseudoaneurysm right here, and got out there with a microcatheter and put microcoils in there. And you can see how much renal parenchyma we maintain. There's a defect in here. You can't see it very well because it's overlying the anterior portion of the kidney, which is well perfused. But this patient lost no renal function at all. This is another one. This was done by a partner of mine. This was a main renal artery pseudoaneurysm, and the goal here was to cover this or fix this problem here while maintaining all this out here. And this was back when we didn't have a shelf load of different covered stents that we could play with. We only had one or two, and one fit the small artery well, but it was very rigid. And when we got it in there, we got a good result on the pseudoaneurysm, but we embolized a lot of the renal parenchyma. But this patient was discharged without any change in her renal function, and she never required a nephrectomy. So we called it a success. We don't really know what happened to this right kidney. She was lost to follow-up. In conclusion, embolization is a valuable treatment in bleeding, especially in a hemodynamically stable patient. If they're hemodynamically unstable, they probably belong in the OR. Hepatic embolization is probably the best friend of the trauma surgeon. It's a very difficult place for them to work around. Look out for the gallbladder, again, and watch out for, there's an increased risk of hepatic necrosis if they have a high-grade injury. Splenic embolization is also very highly successful. You got to give the patient antibiotics. They have a higher risk of infection after this procedure because the spleen tends to be a slightly dirty place. If they have an AV fistula, you're more prone to fail than if it's just a simple extravasation, whether it's intraparenchymal or extraparenchymal. There's still a debate on what the best way to do it is and who should have it done. Renal embolization is also highly successful. It's probably for me anyway, it tends to be the easiest one to do, and we can get very selective in these patients quite easily. And don't forget your friends, the occlusion balloon to buy you some time should you need it, and if the patient takes a turn for the worse while you're working. That's all I got. Thanks.